Welcome to Inside Pediatrics with Dr Chadia Jbeily, pediatrician with medical training from St. Joseph University in Beirut and Université Paris-Cité in France. In episode 3, we will dive into how we assess and manage pain in children. First question, what is the history of pain?
In 1987, Dr. Anand showed that preterm neonates undergoing surgery without adequate anesthesia had significant stress hormone responses. He and Dr. Hickey demonstrated that the premature infant is capable of transmitting pain impulses from the periphery to the cortex. This discovery was a turning point in neonatology. Before that, many believed neonates had immature nervous systems and therefore didn't experience pain the way older children or adults do. Dr. Picard studied the semiology of pain in children and discovered that in infants and preverbal children, psychomotor atony can be a sign of pain. Instead of agitation or crying, some children, particularly very young, exhausted, or chronically ill ones, may show decreased spontaneous movements, reduced facial expression, hyporeactivity, a withdrawn or frozen attitude, and a lack of interaction. This inhibited presentation is sometimes more concerning than agitation because it reflects a collapse of tonic emotional expression under persistent pain. The work of Dr. Tom Tivik shaped how we understand now psychic pain in children. He reminded us that suffering is not only physical, it's emotional, relational, and deeply influenced by attachment, by a child's sense of security, by their environment, and by previous trauma. A child's pain does not exist in isolation. It lives within a story.
Second question, what is the pathophysiology of pain?
Injuries from heat, cold, stretch, pressure, and inflammation activate nociceptors, which are the free nerve endings of peripheral sensory neurons. This first phase is called transduction. Ion channels such as CRP channels or sodium channels open. This leads to depolarization and generates an action potential. This brings us to the second phase, transmission. The signal travels through two main types of fibers. First, A-delta fibers, which are fully myelinated, conduct rapidly at 40 meters per second and transmit sharp, well-localized pain. They use glutamate as a neurotransmitter. Second, C fibers, which are unmyelinated and conduct slowly around 2 meters per second. They transmit burning, diffuse pain, and release glutamate and substance P. The signal reaches the dorsal horn of the spinal cord. There, second-order neurons synapse across to the opposite side and ascend through two main pathways, the spinothalamic tract, responsible for localization and intensity, and the spinoreticular tract, involved in the emotional component of pain. These pathways project to the thalamus, brainstem, and to the cortex. Then comes the demodulation phase. Pain is regulated. In the dorsal horn, inhibitory interneurons release GABA and glycine, reducing signal transmission. At the same time, higher brain centers send descending inhibitory pathways that release endorphins, serotonin, and norepinephrine. Finally, we reach the perception phase when pain becomes conscious in the cerebral cortex. This is when the patient truly feels pain. Pain is therefore a dynamic process involving peripheral activation, spinal processing, brain modulation, and conscious perception. We can distinguish three main types of pain: the nociceptive pain, caused by tissue damage or inflammation, such as fractures or postoperative pain; the neuropathic pain resulting from a lesion or dysfunction of the nervous system, such as nerve injury, and the functional pain, where there is no clear tissue damage but altered central pain processing, for example, chronic headaches or functional abdominal pain.
Third question, how do we assess pain in children?
When we assess pain in children, we always ask the child whenever possible. Self-report is the gold standard. We locate the pain and explore its characteristics, its quality, intensity, duration, and what makes it better or worse. Pain assessment must be repeated regularly, especially after an intervention, to evaluate the effectiveness of treatment. We use developmentally appropriate pain scales adapted to the child's age. For children from about 6 years of age, several reliable self-report tools are available. The Color Analog Scale, or CAS, uses a colored vertical ruler with a movable slider to help the child indicate pain intensity, scored from 0 to 10. The Numerical Rating Scale, or NRS-11, asks the child to rate pain from 0 to 10. For younger children, between 4 and 7 years, the FACES Pain Scale Revise uses facial expression to help the child express pain intensity. A score of 3 out of 10 or higher generally indicates pain that requires treatment. The Wong-Baker Scale is a visual self-report tool using 6 faces scored from 0 to 10. It allows children from age 3 to express their pain intensity by pointing to the face that best matches how much they are hurt. But what about infants, toddlers, or children who cannot communicate their pain verbally? We rely on behavioral and physiological indicators. We observe facial expression, crying, body movements, consolability, sleep disturbance, and feeding difficulties. In neonates, the Neonatal Infant Pain Scale, or NIPS, evaluate facial expression, crying, breathing pattern, and limb movements. The FLAC scale, which stands for face, legs, activity, cry, and consolability, is widely used in infants and young children. For premature infants, specific tools such as the Premature Infant Pain Profile help assess procedural pain. Another important tool is the Evan-Doll scale. It's a validated 15-point behavioral scale for children from birth to 7 years, especially in emergency and acute pain situations. It evaluates 5 domains: vocal expression, facial expression, body interaction with the environment, and consolability. Each item is scored from 0 to 3, and a score of 4 or higher indicates pain requiring treatment. Pain assessment should be performed first at rest by observing the child from a distance, ideally with parents present, or during spontaneous activity. It should also be assessed during examination, mobilization, or palpation of the painful area. Finally, reassessment is essential. Pain should be reassessed 30 to 45 minutes after oral analgesia and 10 minutes after intravenous analgesia. These tools allow us to detect pain reliably, ensuring that no child's pain goes unrecognized or untreated.
Fourth question: how do we treat pain during procedures?
Management in children relies on a multimodal approach that combines non-pharmacological methods, systemic medications, and procedural analgesia. In neonates and young children, methods such as non-nutritive sucking, oral sucrose or glucose solutions, breastfeeding, music, and distraction, including touchscreens, can provide effective analgesia during minor procedures such as heel pricks, venipunctures, or gastric tube insertion. Topical anesthetics such as lidocaine, prilocaine, and emlacrine can be applied before procedures like vaccinations, IV insertion, or lumbar puncture. Infiltrated lidocaine may also be used to provide local anesthesia. An equimolar mixture of oxygen and nitrous oxide, NEOPA, provides rapid analgesia, anxiolysis, and mild sedation for short painful procedures, including IV insertion, lumbar puncture, intra-articular injections, bladder catheterization, and nasogastric tube insertion. Finally, midazolam, Hypnovel, may be used for sedation but should always be combined with appropriate analgesia. Optimal procedural pain management always is tailored to the child, the procedure, and the clinical context. Anticipating and preventing pain is a key component of high-quality pediatric care.
What is the treatment approach for mild, moderate, and severe pain?
For mild pain, paracetamol is the first-line medication and can be used from birth. It's safe, effective, and well-tolerated. Ibuprofen can be used in infants older than 3 months and weighing more than 6 kilos, either alone or in combination with paracetamol. It's particularly effective for inflammatory pain such as sprains or migraines. When pain is moderate to severe or when first-line medications are insufficient, treatment must be escalated. For moderate pain, nalbuphine, Nubain, can be used. It's an opioid agonist-antagonist that provides effective analgesia with a lower risk of respiratory depression compared with morphine. It's particularly useful in post-operative settings or for acute moderate pain. However, like all opioids, careful monitoring of sedation and respiratory status remains essential. For severe pain, morphine remains the gold standard opioid analgesic. It can be administered intravenously, orally, or via patient-controlled analgesia in older children. When carefully titrated according to weight and clinical response, morphine is both safe and highly effective. Fear of opioids should never prevent adequate pain control when appropriate monitoring is in place. Fentanyl is a potent opioid agonist, approximately 50 to 100 times more potent than morphine when administered intravenously. Its onset of action is rapid with a peak effect at 2 to 3 minutes and a short duration of 20 to 40 minutes. These characteristics make fentanyl particularly useful in emergency settings where a dose of 1 to 2 micrograms per kilo provides rapid analgesia. In the infographics, you will find the key pediatric analgesic dosages based on Carbajo's recommendations. From a better understanding of the brain's own pain-modulating system to more personalized treatments and new therapeutic targets, innovation continues to open new paths in pediatric pain management. Thank you for your attention. I look forward to your reflection and to our discussion. Until next time.